very much for the invite. It's a pleasure to be in this conference, the Clinical Update in Nephrology. My name is Arvind Ponnusammy. I'm a consultant nephrologist in Lancashire Teaching Hospital. My topic today is recurrent and de novo glomerulonephritis in renal transplantation. I have no disclosures. In the next 20 minutes or so, I will give a brief summary of recurrent glomerulonephritis in transplant and de novo. The term itself has a lot of confusion at times, and there is interchangeably used interchangeably. I'll spend this slide here to explain exactly what recurrent GN means and what de novo glomerulonephritis means. Recurrent glomerulonephritis means the same disease in a native kidney, and this can be primary or secondary. And in today's talk, I predominantly will concentrate on primary glomerulonephritis, which means secondary type of glomerulonephritis, which can reoccur in transplant kidney. I won't cover, which includes like lupus nephritis, diabetes mellitus. I predominantly will cover FSGS, IgA nephropathy, C3GN, atypical HUS, and a brief word of MGRS. De novo GN, glomerulonephritis, it basically is a disease that presents in a recipient proven to be different from the native kidney. And the issue here quite often is the availability of native kidney biopsy. And most of you would have encountered patients coming with end-stage kidney disease in our practice, and we feel, and with small kidneys, we may not biopsy. And the lack of recipient native biopsy sometimes may be labeled as de novo glomerulonephritis, and that's something needs to be bare in the back of our minds. And working up patients with glomerulonephritis is in transplant patient with proteinuria in transplant patient is slightly different from working up patients in native kidney biopsy. This is because of the background of rejection, and rejection and the early phases do also present with some mild proteinuria. I found this workup, which was published in 2019, when they talked about membranous glomerulonephritis post-transplantation, useful. When a patient has edema or protein dipstick with proteinuria, it's important to send for a spot urine protein creatinine ratio, and of course confirmation with high presence of albumin and 24-hour urine collection. Although in my clinical practice, it's very difficult to do a 24-hour collection practice, so we normally use serum albumin and urine PCR and ACR together. And if that's confirmed the evidence of glomeruloproteinuria, when there is no discrepancy between urine ACR and PCR, it will line towards a glomeruloproteinuria. There are a number of there are a number of thank you. I'm just going to re-slide this slide. Okay. Workup and differential diagnosis of proteinuria after transplantation. Workup in the proteinuria transplantation is slightly different than unusual patients because the presence of proteinuria in patients with rejection. I found this paper, Membranous Post-Transplantation, useful, and I use my patients on basis of this algorithm. If there is a patient with edema and positive urine dipstick, the ideal scenario is to send an early morning urine protein creatinine ratio and a simultaneous urine albumin creatinine to ensure there is no discrepancy. And worthwhile getting a serum albumin and a 24-hour urine collection. Of course, 24-hour urine collection is sometimes cumbersome. So in my practice, we just rely on urine protein creatinine ratio and a simultaneous urine albumin creatinine ratio. If this is confirmed, we will do a glomeruloproteinuria. And this is likelihood of glomeruloproteinuria. And there is a number of causes which can be divided into immunological, which under the immunological will be recurrent and de novo glomerulonephritis, acute rejection, transplant glomerulopathy, which can present with an MPGN pattern, and other causes of proteinuria, which include obesity, diabetes, and particularly the use of sirolimus, which has been associated with an FSGS type of picture. So this requires all a renal biopsy to confirm the diagnosis. Stop. So I'm going to start off with FSGS, and predominantly 3/4 of my slides are concentrated on FSGS, as this being the most commonest or most difficult to treat recurrent glomerulonephritis. Now, FSGS, as we all know, is not a disease, it's more of a lesion. And within the lesion, can be divided to a variety of causes, which include primary, which is a immunological mediated, permeability factor related. There are secondary causes, which are predominantly adaptive, genetic, and also related to other causes like obesity, which do not reoccur in transplant kidney. The recurrence rate in primary FSGS, particularly permeability related, is high, up to 70%. And this occurs quite often soon after transplantation. As I mentioned before, it is a lesion rather than disease. And the only way that we can find changes is by doing light microscopy, by doing a renal biopsy. And the light microscopy of a renal biopsy may not show anything. In fact, when we do day 0 biopsy of these people, the light microscopy may be normal. And it's important that we send an electron microscopy to see for diffuse food process effacement, which will give you the diagnosis along with the reduction in albuminuria. And quite often, reduction in albuminuria may be the only sign, and the proteinuria may be very minimal. So it is important that we use serum albumin along with the presence of food process assessment to make the diagnosis of permeability factor FSGS. Stop. Unfortunately, there's no permeability factor which is identified currently. There is talk of SUPA, soluble urokinase plasminogen receptor, which has been published in New England Journal a number of years ago, but unfortunately the results were mixed. In fact, it's a very non-specific finding. There's some role of cardiotropin cytokines also, which did not pan out to be the true permeability factor. But what is interesting is the role of anti-nephrin antibody, which was published in JASN almost a year ago. And I think this have a weightage to it. And I think the group that found the anti-nephrin antibody has found it's being a possibility of a presence in minimal change disease and FSGS. So I suspect there will be more data on anti-nephrin antibody playing a role in the as a permeability factor. So watch the space with regards to this. With regards to de novo FSGS, there are a number of causes, particularly driven by viral mediated, which could be cytomegalovirus, HIV, and COVID virus, which is more recognized. In fact, it's called COVID associated collapsing FSGS. This is particularly seen in the African population with the ApoL gene related, and most of the collapsing FSGS are related to this particular gene. And medication related, which could be sirolimus or even pemodronate stop. Once FSGS has set in, the graft loss could go between 70% to even 90%, and it's a very difficult disease to treat. Well, how do we predict patients with FSGS whether they will have particularly the permeability factor? Certainly, going back to the native kidney, looking at the rapidity of reaching dialysis. In fact, patients who reach dialysis within the span of 12 to 24 months are very likelihood to reoccur in the transplant kidney. Younger age patient, multi-resistant FSGS. In my patients who've got recurrence in the transplant kidney, number of medications, in fact, they were on steroids, rituximab, cyclophosphamide, all of them didn't work, and that points towards multi-resistant FSGS. In fact, a unique feature is some of them do respond to steroids initially, but subsequent FSGS within the native kidney also a pointer to a early recurrence with FSGS. It's had the special prediction towards the Caucasian race and the presence of low albumin at the time of transplantation. So certainly a patient with low albumin with the native kidney FSGS do have higher incidence of transplantation. And if you have a graft which failed with FSGS in the first graft, the likelihood for a recurrence graft will be recurrence graft with FSGS will be high, up to 80%. Stop. So these are a few pointers towards recurrence of FSGS in the transplant kidney, and this is very important when we counsel patients for transplantation, and this will give us an indicator to a patient with regards to recurrence. And this is important when a patient have a live donor, and whether a live donor would be suitable if a patient have FSGS, and these are difficult discussions to have with the patient. What about prevention and therapy? Well, I've written a number of therapy which includes plasmapheresis, IVIG, rituximab, ACE or ARB, high-dose steroids, and high-dose CNI. I have to be honest, there's no lot of randomized control trial on all of them, are mostly based on observational data, which I'll go through a few of them on subheadings. The first thing is prevention, pre-treatment or plasma exchange. And only one of the papers that I've seen is in Transplantation in 2009, published by Al-Sab. And this is basically an observational data, and the data has not been encouraging though. What they found in patients with pre-transplant plasma exchange, the recurrence rates were 62%, and with patients with no pre-transplant plasma exchange, the recurrence rates 51%, suggesting that pre-transplant plasma exchange may not make a lot of difference. How about rituximab, a B-cell directed therapy? As we know, this is a permeability factor, presumably driven by a B-cell, whether this makes any difference. And here again, a recent paper published in Clinical Kidney in 2021, and where they have 34 patients and 12 patients who had a risk of recurrence received rituximab at the time of transplantation. Similar features of both the group as shown here. The recurrence rates appears to be similar between those who were treated and those who were not treated, with about 40% and 41%, 50% and 41% in both the groups. So both this data suggests that the preemptive treatment with plasma exchange and rituximab did not show any evidence of preventing an outcome, which is pretty dismal. And although having said that, there is different centers practice differently, and certainly I know that our transplantation center do give plasma exchange or rituximab depending on the group, particularly on the higher risk group. How about therapy? I found this paper one of the most useful paper published in Transplantation in 2019, which is a prospective patient data, which is about 66 patients with recurrent FSGS. And out of them, 38 patients had plasma exchange and rituximab. Interesting regimen of plasma exchange where they used 10 sessions back to back, followed by 3 to 5 sessions continuously, and weaning down them to 3 sessions a week and weaning it down. Interesting, all but 5% responded to initial therapy, 4 lost the kidneys to graft recurrence. 14 developed at least 1 relapse after the initial response, but the more relapse on the patients who did not really receive rituximab and 4 allograft losses. So suggesting to me that the combination of plasma exchange and rituximab does help. And I think this is the regimen that we follow in our center. In fact, my patients with recurrent FSGS do have intensification of plasma exchange initially, and after which we wean them down. Some patients do have once a week of plasma exchange, even after 6 to 8 months after post-transplantation, with the background of rituximab given initially. And coming back to a combination therapy, this is a meta-analysis which was performed and which was published in 2020. And this is a meta-analysis of 8 observational studies, and it shows that rituximab and plasma exchange induce complete remission in 41% of patients and partial remission in 32%. So what is the current approach for recurrent primary FSGS? The patient with high risk may be considered for preemptive plasma exchange plus minus rituximab. So the high risk group, those particularly who had end-stage kidney disease, quite rapidity in a native kidney, or those patients who was pre-transplanted after the first primary recurrence in the graft, and this is a second graft, probably a preemptive plasma exchange and rituximab may be considered. Now, the most important is identification of post-transplant recurrence in FSGS, and that requires a biopsy and prompt starting of plasma exchange, and rituximab does have a favorable response, although there is variable response rate. So in my patient group of patients, certainly they do have plasma exchange and rituximab, which is given early on, and some patients has been having plasma exchange or even after a couple of months post transplantation. Next, I thought we'll go to IgA nephropathy, and I think IgA nephropathy, like the kidney, like in a native kidney, is a very heterogeneous. It commonly recurs. In fact, in my experience, do recur with just microscopic hematuria, and there was always a difference in threshold of biopsies. We do not biopsy patients early on with microscopic hematuria. We do send them to urologists to ensure there's no urological problem, and they come back to us post cystoscopy and CT KUB, which do not reveal anything, and subsequently we assume this patient have a recurrence IgA, and if they don't have significant proteinuria, we do not biopsy, and certainly that does affect the incidence rates. And what is in the literature, it found that most of these patients do have a signal of steroid-free immunosuppression as increases the risk of it, which I will show in subsequent slides. And the long term of our graft outcome is variable. Now, certainly in our centers, our regimen are steroid-free immunosuppression, and I don't particularly do put them back on steroids if they have native kidney, but of course, post-renal biopsy in the graft, which shows features of recurrence, we do give them back steroids. So what is the effect of renal graft survival of IgA nephropathy in patients? This is a paper which is published in 2013. As you can see, a Kaplan-Meier curve, which shows the incidence of death census graft survival. As you can see here, it's around 10 years, patients with recurrence and patients without recurrence, and patients around 10 years do see worsening of graft survival compared to those without. As said, this is similar to the disease of in native kidney. It's very heterogeneous and patient needs to be followed up. Certain group of patients do have this disease very early on, particularly those in the native kidney had crescentic in origin. Those with crescentic IgA who developed end-stage kidney disease early on certainly do have this IgA occurring a lot more earlier on. So it is important that we keep an eye on the urine abnormalities and the evidence of proteinuria, and also higher threshold to biopsy them. Now, what are the risk factors for IgA nephropathy recurring in the transplant kidneys? Now, the disease severity, like the FSGS, is similar. The time to end-stage renal disease. I think that's quite often an important predictor. Steroid-free regimen, and certainly in the data suggests that patients with steroid-free regimen do have higher incidence of IgA nephropathy recurrence in the transplant kidney. There is no specific biomarkers, although elevated IgA may predict the risk, but I think it's just there is no enough data. We know that from the IgA nephropathy group of patients, particularly in the native kidney, the rise of underglycated IgA and the presence of antibody, antiglycan to underglycated IgA predict the risk in native kidney, but we do not have the similar data in transplant kidney. Although I think in the future, monitoring underglycated IgA nephron levels and also antibody may have a role. Now, it's important to also note that lots of us do have deposition of IgA in our kidney without any clinical consequences. Now, if you biopsy these patients at the time zero biopsy at the transplantation, they may have deposition of IgA from the donor. Now, it may be a secondary effect on the biopsy, a secondary phenomenon, and they then develop an antibody against the underglycated IgA, which is deposited in the patient, in the donor kidney, and they may then develop IgA nephropathy on the long run. So this is several risk factors that guides us into an IgA nephropathy patients. Now, this is the paper which was published in 2014 in Clinical Transplantation, where the recurrence of IgA nephropathy patients in a steroid-free regimen, where although be it very low, only 27 patients with IgA nephropathy had recurrence at 7-year follow-up, but the hazard ratio is about 8 times for steroid-free regimen. Now, we also know most of our patients on TACR and MMF, and this doesn't seem to protect them from developing IgA nephropathy, and only the presence of IgA, a presence of steroid-free regimen, which puts them at a higher risk on IgA. Well, that begs the question whether all patients with IgA nephropathy were being transplanted, or whether we should put them in steroids. And this data with that is very variable, and it depends in a variable from center to center, or which doing the transplant. So what about treatment of IgA nephropathy? Well, there's mostly observational data and case reports. Unlike in the native kidney, the data are not very strong. The data in Rituximab also are similar to data in native kidney. It doesn't work, and I've not personally used Rituximab in IgA nephropathy patient, and even in native kidney or in transplant kidney. Of course, when you have a crescentic patient in transplant kidney with rapidly worsening renal function, then I suspect you may need to treat them with crescentic IgA nephropathy, and there will be a role on cyclophosphamide and plasma exchange. And the use of budesonide. There is no any trial, but all this is extrapolated from the native kidney. The Nefficon trial has considerable amount of data. In fact, FDA has approved the use of budesonide in native kidney to use not for renal endpoint, for reduction of proteinuria. Certainly, there will be a certain role for transplant kidney, and I think there is a role for it. Now, the use of steroids on steroid native patients. I do put my patients on steroids as soon as confirmation of IgA nephropathy in the native kidney. So unfortunately, there is no any randomized controlled trial. It's just mostly case report. My practice, I put them on steroids if they have confirmation of IgA nephropathy, or consider budesonide. How about membranous nephropathy? Now, the membranous nephropathy, there is a recurrence rate about 25 to 40% in renal allograft. The time for recurrence is very variable. It could go from anywhere between 6 months to 5 years. Interestingly, the presence of PLR2 prior to transplantation predict the risk of recurrence. Now, what do we do about them? The data, it's not there. Certainly, we have of patients we would transplant who have PLR2 positivity. We do have the discussion with the transplant team whether we should give them rituximab to ensure complete clearance of the antibody. But currently, the presence of antibody should not stop a patient from getting transplantation, provided we do adequate counseling. Now, what is interesting is that de novo membranous nephropathy are generally PLR2 negative, and unlike the recurrence where we see PLR positivity. Now, this suggests to me there is certainly a different antibody which is there, which has not been seen, detected yet. As we know from Sanjeev Sethi's work, a number of new antibodies have been found, like NAL1, somatotropin, proteoglycan, thrombospondin. All of these scenes in native kidney. I suspect in the future we will find a particular antibody for de novo membranous nephropathy in transplant kidney. What about therapy? Is similar to the native kidney. Blood pressure control, controlling them, targeting along 130 or 80, use of statin, rituximab, which is my #1 therapy for for native kidney, is similar to the transplant kidney. Certainly the role of cyclophosphamide, depending on the severity of the disease. There is no randomized controlled trial. I think if the patient has significant nephrotic range proteinuria, particularly more than 4 to 5 grams, on full ACE and up, certainly my choice would be rituximab. And if they are PLR2 positive, certainly rituximab will be my first choice. Now, I found this clinical evaluation of management of recurrent membranous very useful, which was published in 2019. Certainly, when you have a management of recurrence, monitoring this PLR2 positivity every three months, and any detection of proteinuria suggesting the use of biopsy, and all the titers going up, whether there is increased titers going up or increased proteinuria, a biopsy is indicated, following which a combination of supportive therapy and immunosuppressive therapy, particularly rituximab, has been useful. Coming back to MPGN pattern of injury. Now, we all know, like FSGS, MPGN is a pattern of injury. Now, as I was preparing for this talk, there was a nice paper which was published in 2020, only this year, and I think this paper sums up the entire MPGN pattern of injury in kidney transplantation. This is a retrospective cohort in 11 hospitals, significant time of follow-up within a median time of 79 months with 220 kidney graft biopsy, which shows the features of MPGN pattern. And what they found, the main predictors were the development of rejection and recurrence is particularly complement mediated and dysproteinemia. And the early time to recurrence also suggests from the albumin. So 1/4 of the patients with native kidney due to MPGN pattern develop clinical recurrence, particularly the case of complement mediated and presence of paraprotein. Now, in my practice, certainly patients with low complement with history MPGN, we will sometimes do not try to transplant them unless we treat the complement-mediated disease, and particularly also paraprotein disease. We know paraprotein disease, presence of paraproteinemia, and transplantation can particularly reoccur if the transplant in the native kidney does have evidence of paraprotein related disorder like monoclonal gammopathy or renal significance. This is very important. It proves the validity of MPGN being classified into immune complex mediated disease, or MPGN. As all of you know, in a number more than 20 years ago, when we classify MPGN as type 1, type 2, type 3, this classification is completely changed into immune complex mediated MPGN, C3 glomerulonephritis, and just another pattern of injury like dense deposit disease. And I think the movement of this classification to this classification to immune complex mediated classification or complement classification allows us to identify patients who are high risk for recurrence. To summarize this, immune complex MPGN does not reoccur. Autoimmune disease does not reoccur. Infection does not reoccur unless the persistence of infection. Monoclonal gammopathy, MPGN patterns does reoccur. C3GN does reoccur. Dense deposit disease does reoccur. So under C3 glomerulopathy, we all know of C3 glomerulonephritis, which has high incidence of recurrence, about 70%. Now, the recurrence, what are the predictors of recurrence? Low complements are presence at the time of transplantation, presence of crescents on the native biopsy also predicts the recurrence. There is no specific treatment. Various treatment has been tried, particularly use of MMF. In the native kidney, the same extrapolated data, although the response are variable. Now, the use of Rituximab, which is a C5 inhibitor, has shown some improvement. And in the UK, we do refer this patient to the Newcastle, which is the complement center, and it is looked at case by case for consideration. And there is some data on Rituximab with regards to C3 glomerulonephritis. What about dense deposit disease? Likewise, dense deposit disease have high incidence of recurrence, up to 70%, and resulting significant allograft failure. Here, like other C3 glomerulonephritis, the treatment of Rituximab have shown some improvement. Plasma exchange has shown some benefit, but the data is pretty variable. And all the dense deposit diseases are mostly associated with some form of complement factor mutation, particularly C3 nephritic factor. I'm going to end with looking a short slide on other diseases, like particularly FSGS. As we all know, there is an staining, DNA JB9, which has been stained in native kidney and also in transplant kidney. It is a slow progressive disease. Time to recurrence it's about 10 to 12 years. In fact, I've got 2 patients who had recurrence of FSGS, and there's no particular treatment. It's particularly controlling blood pressure, and the graft do fail, but the only thing is there's a slow progression to recurrence. In terms of anti-GBM disease, we do not transplant anybody with anti-GBM disease presence or positive, but patients who have got anti-GBM or on positive or on dialysis who needs to transplantation, we do sometimes give either azathioprine or rituximab to ensure they become anti-GBM positive negative, to ensure the negativity of anti-GBM to allow for transplantation. Now, patients with Alport disease who then get transplanted do have features of anti-GBM, but they are with undetectable titers because the assay for anti-GBM are directed to alpha-3 non-collagenous domain, unlike the Alport, as we know, is type 4 collagen alpha-5. So biopsy features shows crescents and also staining the kidney biopsy with immunofluorescence showing leaning IgG will be able to, for us to detect the degrees. Like I've commented on the monoclonal gammopathy of renal significance, patients with high serum free light chain and presence of paraprotein prior to transplantation, it's an indicator of recurrence in the transplant kidney. ANCA positive vasculitis is not a contraindication. Patients with positivity are allowed to transplant provided the disease in remission. Thank you very much for this opportunity. I'm happy to take any questions.